live stream.
Good evening and welcome for today's discussion. We're going to be talking about meningitis, and you will watch a video that will show you some details about meningitis, right?
Hi, I'm Sherilyn Smith, a pediatric infectious disease doctor at the University of Washington, and in this video you will learn about the potentially life-threatening illnesses meningitis and encephalitis. We will be focusing on the clinical presentation of these illnesses because rapid recognition and treatment of the illness may allow you to save someone's life in the future. Here are the learning objectives: to compare and contrast meningitis and encephalitis, and to outline a diagnostic approach to the patient with meningitis. First, I'd like to define some of the terms I'm going to be using. The different layers of the meninges that cover the brain are called the dura, the arachnoid, and the pia mater. As you can see in this cartoon, normally they are very thin membranes that cover the brain. Cerebral spinal fluid, or CSF, is in the subarachnoid space, which surrounds the brain. This fluid serves to cushion the brain, provides nutrients and chemicals from the blood, and removes waste from the brain parenchyma. Meningitis is inflammation of the meninges. You can see here in the photo of a patient who died from meningitis due to strep pneumoniae that when there is inflammation of the meninges, they become thickened and no longer translucent. Patients who have meningitis will have fever, headache, and stiff neck, or nuchal rigidity. Encephalitis is defined as inflammation of the brain tissue, as shown in the cartoon. The image in this slide is from an MRI of the brain of a patient who has encephalitis due to herpes simplex virus. You can see that there is increased signal intensity, or white color, where the arrow is, indicating inflammation. Patients who have encephalitis have fever, change in mental status, and sometimes seizures or focal neurologic symptoms because there's inflammation of the brain tissue. Meningoencephalitis is inflammation of both the meninges and the brain parenchyma and is used to describe patients who have clinical features of both encephalitis and meningitis. It is not surprising that patients could have both processes given the close proximity of the brain tissue and the meninges. These patients have fever, headache, change in their mental status, and possibly seizures or focal neurologic symptoms like weakness. Myelitis is inflammation of the spinal cord. Patients with myelitis can have localized neurologic dysfunction depending on where the inflammation is. Certain infections can cause transverse myelitis, which involves both sides of the spinal cord at a specific level and interrupts the communication between the peripheral and central nervous system. The arrow in this image shows localized inflammation of the spinal cord, which is typical of transverse myelitis. Putting it all together, you can see that patients will likely present with a combination of symptoms and physical exam findings. The specific symptoms and signs can help you localize where the infection is anatomically, and it may help you decide which organisms are more likely to cause infection. And I think of four main ways that patients develop meningitis or encephalitis. The first way is through direct inoculation of organisms into the brain tissue or CSF. We see this most often after head trauma, and the infections are mostly due to bacteria. Another way that meningitis occurs is when an organism is present in the blood causing systemic or whole body infection. The organism can cross the barrier that exists between the blood and the brain tissue through a variety of methods, and we're going to talk about this in the next couple of slides. Sometimes organisms, particularly viruses, directly infect nerve tissue and spread to the brain. And finally, infections in the sinuses around the eyes can spread to the brain directly due to the close anatomic proximity of these structures to the brain. This cartoon illustrates how some organisms can cause meningitis or encephalitis by crossing the blood-brain barrier. Bacteria are in the bloodstream and bind to the endothelial cells via cellular cytoskeletal rearrangements. They are then endocytosed and killed by intracellular mechanisms. However, as part of the immune response, cytokines are released, which results in changes in the tight junctions between the endothelial cells, and leukocytes can migrate into the CNS via chemotactic gradients. So the bacteria can actually take advantage of this change in the tight junctions and pass into the CSF, or they may hook a ride on some of the leukocytes that are coming in to the CSF from the blood. The bottom part of the cartoon helps you visualize how infection of the meninges happens with bacteria moving from inside the blood vessels through the blood-brain barrier and then into the CSF and the meninges. So how do you recognize someone who has meningitis? I already mentioned clues from the history, primarily fever and neurologic symptoms. But when you do the physical exam on a patient with meningitis, there's some specific signs that you're looking for. First, you will see if there is inflammation of the meninges. This is done by stretching the meninges during the physical exam maneuvers, as shown in the cartoons. You can see that when you have the patient on their back and they extend their knee, they will have pain in their back. In addition, if you have the patient on their back and you flex their neck, they will involuntarily move their knees due to the pain. These are the Kernig's and Brudzinski's signs, and they were first described with advanced TB meningitis. In addition to evidence of meningitis, you will look for specific neurologic defects like weakness and determine how alert and oriented the patient is. Finally, you will do a complete and careful physical exam to find other clues to the etiology of the infection. You may see a rash like this one in the picture called petechiae, which you can see with Neisseria meningitidis infection. Since you may not know exactly what is causing the patient's symptoms when they come in with fever and neurologic symptoms, the initial evaluation is the same for all types of meningitis and encephalitis. The gold standard evaluation is direct sampling of the CSF by doing a lumbar puncture. A needle is inserted in between the vertebra into the lumbar cistern and the subarachnoid space where the CSF is. The standard evaluation we do is determining the opening pressure to find out if the infection is causing increased intracranial pressure, which can damage brain tissue. Bacterial cultures and gram stains to modify therapy quickly. The combination of glucose and protein, which will change with inflammation and can give clues to the diagnosis early on, and always save brain tissue early on, and always save an extra tube of CSF for more studies. Sometimes, if there's a concern about increased intracranial pressure from the physical exam or the history, we'll obtain a CT scan of the head to make sure we don't accidentally cause a complication related to the lumbar puncture. This table outlines some of the results of the tests we order when we do a lumbar puncture. Keep in mind that specific organisms that cause meningitis or encephalitis can cause slightly different results. It is critical that you recognize bacterial meningitis because it is a medical emergency, and this is outlined on the first line of this table. The combination of lab values that points to bacterial meningitis is a low glucose, high protein, elevated white blood cell count, primarily neutrophils, and a gram stain that shows bacteria. Ultimately, the cultures will grow bacteria, proving that the patient has bacterial meningitis. So why do we see these changes in the CSF? The glucose is low because the bacteria consume glucose and because less glucose is transported into the CSF. The protein is elevated because of increased bacterial replication, bacterial death, recruitment of white blood cells, and increased levels of immunoglobulins and other proteins as a part of the immune response. Normally, white blood cells, immunoglobulins, and complement are sparse or absent from the CSF. This situation allows the bacteria initially to multiply without causing inflammation. Later, bacteria release endotoxins, teichoic acid, and other substances that trigger an inflammatory response. There is an influx of neutrophils and elaboration of additional inflammatory mediators like TNF, which are important parts of the immune system that can control bacterial infection. You can see here that with encephalitis, the glucose and protein are normal. The white blood cell count is elevated, but not to the same degree as seen with bacterial meningitis. The types of white blood cells are lymphocytes, which makes sense because viruses are some of the most common causes of encephalitis, and lymphocytes are critical for control of this type of infection. In summary, meningitis is a potentially life-threatening illness that requires rapid recognition. Your initial clues to this diagnosis are fever and neurologic symptoms. Doing a lumbar puncture is the diagnostic test of choice, and interpretation of the initial CSF results can guide your management.
So guys, I believe you have seen the video, and you were able to get a good grasp, or at least get a good introduction to the topic. So now we're just going to quickly look at Samson's PLAB notes, okay, to get better grasp. Okay, so by way of definition, meningitis is basically inflammation of the CSF, right? Whenever you talk about meningitis, you are talking about the inflammation of the Okay. So now the causes include bacteria, viral, and fungal. Okay. Now the commonest causes varies with age. For example, in children, commonest causes will be different from in adults, right? But because we are talking about adult medicine, we'll go ahead to talk about the commonest causes of meningitis in adults. So there is like a triad. Okay, streptococcal pneumonia is the commonest in adults, commonest cause of bacterial meningitis. All right, then followed by Neisseria meningitidis, and usually you suspect Neisseria meningitidis in the meningitic belts. For example, if you go to very hot areas, not suspect Neisseria meningitidis, and usually it comes with a rash, like you saw in the video, comes with a, a pustular rash, okay, kind of petechial rash, right? And it's non-blanching. That's how you know it's from meningococcus, all right? It's non-blanching. Like when you place a bottle over it, it doesn't blanch. Okay, then Listeria monocytogenes is considered in elderly people with the extremes of age, right? Elderly people and children consider Listeria monocytogenes. Okay, then tuberculosis patients say Africa and Asia, endemic in areas like Africa and Asia. Just consider it especially when it runs a chronic course. Okay, right? So consider tuberculosis. Now, for the viral, you should think of um, mentioned there's things like herpes simplex type 1, Epstein-Barr virus, cytomegalovirus. But usually, viruses don't cause meningitis. What they tend to cause is encephalitis. So when you see viral meningitis, you should be thinking more of that there is usually an associated meningoencephalitis. Okay, so usually both encephalitis and meningitis when viruses are involved. Okay, now for things like protozoa, Cryptococcus pneumoniae should come in, and it's usually for immunosuppressed patients when you consider Cryptococcus pneumoniae. Then leukemic infiltration, there's history of leukemia. Then malaria in patients with recent history of travel to endemic area, like a patient that doesn't have an immunity. Remember, cerebral malaria, okay, present with meningitis-like features. Okay, so we'll just take the first three causes that they mentioned: strep pneumonia, Neisseria meningitidis, Listeria monocytogenes. Okay, and coincidentally, these are also the ones that cause bacterial pneumonia. Okay, when you mention streptococcus pneumonia, you mention Haemophilus influenza, then you also mention Neisseria meningitidis. They also cause pneumonia as well as um, meningitis. All right. So the symptoms, first of all, patient will give you a history. In fact, it's a triad of fever, headache, and neck stiffness or neck pain. When you have that triad of fever, headache, and neck stiffness, you must consider meningitis. All right. So if there are other features like features of raised intracranial pressure, like vomiting, okay, condition, right? All these things are things that will tell you, give you an idea that this patient may have raised intracranial pressure, especially when the vomiting is projectile, right? So you have fever, neck stiffness, and headache, tired of meningitis. So for you to consider encephalitis as well, for example, when you're considering that a virus might be involved, you usually get a history of altered sensorium, a history of irrational thought or behavior. Okay, so when you get that history of irrational thought or behavior, or history of altered sensorium, you should suspect that there is an associated encephalitis. So when you add those triad of meningitis with history of irrational thought, history of altered sensorium, then you should consider meningoencephalitis. Then you should also look out for a rash, because a rash will give you away the etiology automatically. So when you see a patient that developed a rash, especially petechial rashes, together with history of fever, headache, and neck stiffness, consider meningococcemia. And also because meningococcemia comes as an epidemic, so you should consider it in when there is an epidemic, when there are other people, history of other people too that have had similar symptoms, neck stiffness, headache, fever, that the patient may have come in contact with. Okay, so I'm giving you clinical points that will be very useful for you, right? So the non-blanching rash, like I told you earlier. Now, when you now want to examine the patient, all right, you should look out for signs, certain signs. When the patient has already given you a history of neck pain or neck stiffness, right, you should now want to examine. You check for nuchal rigidity, right? Then from there, you want to do Brunski, like you saw in the video. It's just about flexing the neck of the patient, trying to use the chin to touch the chest, right? So if the patient winces or flexes the leg, Brudzinski is positive. Then you also look out for Kenix. Kenix is essentially you flex the thigh, okay? Then sorry, you flex the thigh, then you extend the leg, all right? So when you do that, cause pain, you are stretching the meninges to their maximum, right? So it will cause a lot of pain and the patient will wince, okay? Or try to flex the neck to adjust, right? So that's Kenix sign. There's another one called Lasix sign, Lasgue, Lasix sign. You can check out that one, but that one essentially is kind of a modification of Kenix sign. What you do is you pick the two legs and raise them up at the same time, up to like 90 degrees vertical, which from supine that the patient is lying. You raise the two legs together. It also give you similar wincing and pain like in next time, right? Then you look out for photophobia. You, of course, you shine torchlight into the eyes, trying to look out for the reflexes, the eye size, and other signs. Okay, and if you have an ophthalmoscope, you may want to look into the fundus, all right, trying to determine whether there is papilledema, which is a sign of raised intracranial pressure. And usually, when there is raised intracranial pressure, you want to avoid doing a lumbar puncture. It can cause a lot. It can cause herniation. That's sudden onset, the congestion that comes with opening tap, opening pressure, and all those things can cause sudden coning for the patient and patient lost. All right. So you want to avoid doing that when you have confirmed that there is raised intracranial pressure, at least until there's evidence to the contrary. So management of meningitis. Essentially, you are going to, because it's a bacterial meningitis, you are going to treat antibiotics that targets the meninges, right? That have high CSF penetration. Because it's not every antibiotic that can cross the blood-brain barrier. Some antibiotics cannot cross, but things like ceftriaxone can cross. It has a very, very high chance that you are going to use ceftriaxone. Usually high doses, up to 2 grams, 2 grams BD, we do that, right? So now let's look at what we have here. If you suspect meningitis and you are outside the hospital, commonly in the GP, you should give 2.4 grams of IV benzyl penicillin, all right? And the patient should then be sent to the hospital. Now, the problem with penicillin is that there's a lot of resistance surrounding it. So people tend not to go for penicillin. Third practice, I've never really used penicillin, okay, but it still works anyway. But when you're in the hospital already, why not go for ceftriaxone? And when you want to go for ceftriaxone, you should go for the branded ones like Crucifin, okay? Those are the ones that are known from trusted companies. So ceftriaxone or cefotaxime, like I told you, you have to go for the third generation cephalosporin antibiotics. Now you look for rash. If patient has got a rash, then do blood culture. Of course, part of the investigations you will do. Have we talked about investigations? No, we've not talked about investigations. Before treatment, you should actually do investigations. Investigations include lumbar puncture, which is kind of diagnostic. Of course, you do your blood culture. You are trying to look for the cause. You want to know whether it's hematogenous, whether it is direct. Of course, when you're examining the patient, you want to look look at the ears, want to know whether there is any otitis media with suppuration. Okay, want to know whether there is any sinusitis, chronic or acute sinusitis. Want to know whether there is any conjunctivitis. These are all possible. Anything around the face, possible. Even dental abscesses, dental problems can also feed bacteria into the blood and directly into the brain. And of course, if patient has had head trauma, you see the direct effect of the head trauma. You see the evidence there on the head. Okay, so if no rash, right, you do lumbar puncture, but check that there are no signs of raised intracranial pressure like drowsiness, papilledema, focal neurological signs, right? Headache and vomiting are not very reliable signs of raised ICP in meningitis, as most of the time meningitis presents with vomiting and headache. But look out for papilledema. When you look into the eyes, that's very classic. Then when you see anisocoria, right, when you see that the pupils are unequal, it also gives you an idea that there may be raised intracranial pressure. Okay, and things like drowsiness, altered sensorium, generally coming with meningitis, give you an idea that there may be raised intracranial pressure. Right? Then so if there are signs of raised, you have to do a brain CT scan. But if there are no signs of raised intracranial pressure, you can go ahead to do just your lumbar puncture. But note that brain CT scan may not show you and may not be able to show you the lesion, right? It's meninges that are inflamed after all, so you may not be able to pick it up on brain CT scan. So the head, in order to rule out raised ICP, if CT proves there is raised ICP, do not do lumbar puncture as there is a risk of herniation of the brain. If there are no signs of raised ICP, then do lumbar puncture straight away. So if the patient is more than 55 years of age, you usually add ampicillin to cefotaxime to cover for listeria, right? But if listeria has been identified as agent, you can give ampicillin and gentamicin. Remember that listeria is like a gram-negative organism. Okay, so you want to give things like gentamicin that has great gram-negative cover for listeria. Okay, but apart from that, you should use third generation cephalosporins and ampicillin and things like your benzoyl-penicillin IV, right? So key points in management: GP should give benzoyl-penicillin or third generation cephalosporin before urgent transfer to hospital. Give chloramphenicol if there's history of anaphylaxis to penicillin or cephalosporin. No, chloramphenicol is also a broad spectrum antibiotic, right? So in case of meningococcal and meningococemia, meningococcal meningitis, you want to give benzyl penicillin, just the same thing, for at least 5 days. In case of pneumococcal, that's Streptococcus pneumonia meningitis, once you give the same third generation cephalosporin or benzyl penicillin for 10 to 14 days. So you tend to treat longer if it's pneumococcal, and this is the commonest organism. So it means for most patients, when you start an empiric treatment, you have to aim for 10 to 14 days. Okay, then if resistant, you can add vancomycin. Then hemophilus influenza, like I mentioned, is one of the causes of pneumonia and is also one of the causes of meningitis. Use a third generation cephalosporin for 10 days. So just aim for that 10 to 14 days. Then for listeria, you want to go for amoxicillin and gentamicin. Amoxicillin covers the gram positives, while gentamicin covers the gram negatives. All right, so listeria monocytosis is usually gram negative. Am I having a network issue? As in this part. Anyway, so that's basically that about that. Any questions so far concerning meningitis? Is it gram negative, gram positive? Area. There are like very few gram positive organisms. There's strep pneumonia, streptococcus, staphylococcus, corynebacteria, diphtheria. Just very few gram positive organisms. that once you use the gram positives, the rest are essentially gram negative. Let me check. May be correct. All right. Okay. Thermal monocyte is gram positive, non-spore forming, motile, vacuole, anaerobic, rust shaped. Okay. Cafalus positive and oxidase negative. All right. So it's gram positive. Let me look at the gram positive organisms again. It has birthday. 20 years. All right. Yeah, they can. They can. Remember, the meninges are just close to the brain. So let's say there is organisms growing on one part of the meninges that is very close to a particular part of the brain, and they touch on the motor cortex. Definitely, there may be focal neurologic signs. Yes, you can present with that. And that in itself also gives you an idea that there may be raised intracranial pressure. Remember, raised intracranial pressure usually comes with things that cause increased kind of space occupying lesions. But just plain meningitis that is just affecting meninges may not cause raised intracranial pressure. But when there's now, let's say, suppuration in addition, or there's inflammation of that part of the brain would swell up, right? There's kind of brain inflammation, right? And the brain will now swell. That edema around that side will now cause increase in the brain mass, which will now lead to raised intracranial pressure, essentially. So yes, you can present with focal neurological signs. Okay, yeah. So the gram-positive organisms, okay. Cocci, yeah, cocci are staphylococcus and streptococcus. Then the bacillus are corynebacteria, clostridium, yeah, bacillus, and listeria. So how would you differentiate it from high-level transverse myelitis? Myelitis is talking about the spinal cord. Definitely, you are going to get features that are relating to lower motor neuron signs and all those kind of stuff. Okay, and when you're talking about transverse myelitis, it means it will pick both sides. I think it's logical that it's going to pick both sides. Okay, for focal neurological signs that are related to meningitis, we are likely just going to have hemi, right? Let's say hemiparesis. Well, transverse myelitis may give you a paraparesis, okay, or quadriparesis. Like an idea that this thing is transverse. It's going to cover all the aspects of the spinal cord. Okay, but something from meningitis, if it's focal, that word focal implies that it's going to be hemiparesis on one side. So that whenever you see anything that is hemi, usually it's coming from high up. So I think that in itself can help you differentiate any of them. So essentially classification of gram-positive organisms. So essentially we have like six gram-positive organisms. Cocci, classified measure broadly into cocci and bacillus. Okay. Anyway, any more questions? Let me see if I'm having loaded up. So we're basically almost done with neurology, just a few more topics.